I think we have time for 10 minutes maybe of questions before we hear from we have some public presenters. I want to leave some time for
comments and two comments and a question. One comment is that in thinking about survivorship and how patients and survivors feel about the language that we use and what we say to them and what we expect, let's try to just completely lose the terminology patients failed chemo. I heard it a couple of times, and I know it's not particularly relevant to this discussion, but just as a matter of course, and it does have to do with your survivorship and how you feel about yourself and how you feel about the people who are taking care of you. Also, the issue of survivorship, we didn't mention, I'm so sorry. We didn't mention palliation at all, and that's a really important issue in terms of survivorship. And when I talk about palliative care, I mean from the beginning of from your diagnosis onward. So let's make sure that we include that in the discussion, and I'm sure others will bring up other points.
Yeah. So Karen, where'd Karen go? I warned you I had this question. So it's not clear yet what we want to disseminate or implement in this field. We need to discuss it internally. But as a general question, when what you're interested in is not guidelines or interventions, but information, are there different strategies that you recommend or have found useful in disseminating information, knowledge to providers and to the public?
Yeah, I mean, I think as I tried to illustrate, certainly, information campaigns. Oh, I'm sorry. Thank you. Mass media has been used quite a lot, trying to really integrate messages into the sort of public discourse. I think certainly in ovarian cancer, having a celebrity make choices around her own body, Angelina Jolie, put that issue out there, and certainly that is a way to get information to people when those kinds of things happen. So mass media, certainly through social networks and professional networks to providers, very, very important strategies to use for information dissemination. Those are the kind of the standard strategies. Quality campaigns can also be helpful.
That's a follow-up question to that. So, ovarian cancer is a woman's cancer. So ovarian cancer is a women's cancer, which means, the dissemination of information to the patients or the targets are to women. And I was wondering if, an interesting area for exploration is whether there's really gender-specific methods for communication that might be particularly relevant to this patient population. I know we have some early information from one of my students that self-advocacy means something different among women than it does for men, and that sort of strength through connectedness, and whether there's a possibility for leveraging those ideas.
I don't know of whether or not any of the social studies looking at social have differentiated by uptake of information by men and women, if there are gender differences there. My gut would be yes, that social probably works better for women, but I would imagine that, I'm not aware of any studies that have looked at that. Do you know, Deb?
Well, one place is dietary change. So dietary change for women works best when you go to women and get them to change their diet. And dietary change for men works best when you go to the women and get them to change their diet.
Yeah.
That's a pretty common.
Yes, that's a great example in terms of implementation.
So
Yeah.
when something is very gendered in the way that we structure it and bring it about, like maybe even things that go through physicians might be another example, although I don't know anybody who's directly approached it.
Yeah, it's a very good example.
So your example about hypertension was very nice, but hypertension is a very widespread problem that's costing a lot of money, but ovarian cancer is much rarer, and I think the idea of sort of making these very large health system-wide changes may be more challenging because there may not be as much financial benefit from the medical institution. So can you address whether you think that's actually a concern, and if so, how might that be overcome?
Yeah, I actually think that many of these organizations, I'll speak for the one I'm in now, really cares deeply about patient experience and patient outcomes. And so certainly when there are financial incentives, and you can use some of those savings to then implement. I mean, you know, this was an intervention that had some cost to it, and so there was some benefit about being able to bring, have cost reduction that could be brought in to then implement the intervention. But I believe myself, and having spent a lot of years in a cancer center, that there is a really strong desire to have people have better outcomes. And I think that when there is effective evidence, when there's enough evidence, I do think organizations will start to put that in place. And I think there are a lot of ways to push organizations to do that. So, you know, the advocacy groups have a tremendous role in getting organizations to be aware of where there are innovations and where they want to have access to that. And I think that's been one of the great empowering aspects of the social platforms, is it's really brought people together who otherwise would have been very much alone to push organizations to take action where they otherwise haven't. So that's my belief.
Yeah, question. Can you think of examples? I think we might be in a situation like that with ovarian cancer, where we don't think that something's ready for dissemination, but it is occurring, kind of out from under us a little bit. I'm thinking of the example that came up this morning about using physicians using the panel, the genetic panels, and recommending surgeries without complete guidelines around what to do and how to do it and who should do it and why should we do it. And can you think of examples of where we've been successful in sort of holding back the floodgates? Or do you have any suggestions from the dissemination literature of how to hold back the floodgates when holding has to be a little bit more active? Then, you know, not a good idea, guys.
Yeah. I'm sure.
Right. Well, there you go.
What was that?
Lack of reimbursement for the surgery.
Yeah, so changing the incentives up, matters. I'm sure I'll think of several good examples when I'm in the cab on the way to Dulles shortly. But in terms of the, what we can do, I mean, I think changing incentives. I also think that we now are at a place where we have a different relationship with patients than we have in the past. We're bringing them in, we're empowering them in their health care. And so I think sharing, disseminating to patients what we do know, what we really do know, and what you really want to think about is a very, very important strategy that we should be thinking about. Putting information and decision-making in patients' hands so that they understand.
I have one more question to sort of wrap things up and bring it back around to Larry and Susan. So in terms of dissemination and implementation, do the two of you feel like we're at that stage with cognitive behavioral interventions or some of our, so you talk a lot about using multimodal interventions to reduce stress. So the question is it all about stress? Is sort of one aspect to that, so that we should be sort of disseminating information that we should be doing all that we can within clinical settings to reduce stress? Or is there...
You misinterpreted what I was meaning by multimodal interventions. So when I say multimodal, I'll come get the mic. When I say multimodal, my intention is that it is something that targets stress, something that targets diet, something that targets exercise, but all these modifiable behavioral factors are addressed in an intervention. There aren't many that do that. Lorenzo Cohen is doing one of those at MD Anderson right now with breast cancer patients, but they're the exception rather than the rule. Barbara Anderson, whose survival study I showed, was also telling people to exercise, and she was targeting health behaviors, and that may be why she was successful where other people who were just being strictly psychological were less successful. But in terms of, there are some cognitive behavioral stress management is, it's there, it can be, it's ready to be disseminated. I think funding is the issue, so dissemination is based on funding. And so that's what I have to say.
Tag team here. So I think in terms of just clinical applicability, one way that I might roll this out, and we've been able to do this with some success with cervical cancer survivors. This is a much different population, but I still think that you can find thresholds of distress, however you want to define that. It might be low quality of life. It may be increased symptomatology of depression or anxiety, maybe sexual dysfunction or gynecologic problems that are persistent. So you can create an algorithm around what this threshold of distress is and utilize that. So it is cost efficient, because leaving people with that level of symptom and distress ultimately is going to cost everyone money. And obviously impaired quality of life. So one approach I would recommend is, okay, let's utilize an algorithm or some screening opportunity to be able to assist those people who need it most. And that can still be evaluated.